Good afternoon, I'm Tony Dalby. I'm a cardiologist at Mill Park Hospital in Johannesburg, and I'm speaking about the pathophysiology of acute coronary syndromes. I have no disclosures to make in regard to this presentation, and if we consider the treatment of acute coronary syndrome from the clinical point of view, we should realize that it's directed at an epiphenomenon. The sketch on the right-hand side of the slide shows a vessel that has been cut open, exposing plaque beneath, which has ruptured, and within which thrombus has formed, and that thrombus is extended into the lumen to cause occlusion of the coronary flow. So, understandably, our treatment is directed at the prompt restoration of flow and the prevention of recurrent thrombosis. After that, our longer-term therapy will be directed at preventing the progression of atheroma with both statins and ACE inhibitors. But despite our treatment, there is a high ongoing event rate after acute coronary syndrome. And if we look at this graph, we'll see that the rate of death and non-fatal myocardial infarction is high, especially within the 3 to 4 months following presentation. This is shown in the blue line, and this extends for up to 12 months after the event. This is in sharp contrast to what happens in stable coronary artery disease, which is depicted here in the green line, and in primary prevention in the red line, where the incidence of events is very low. The current treatment after an acute coronary syndrome also aims to prevent ongoing and recurrent thrombosis. And for more than a decade, we've known of the CURE trial that looked at dual antiplatelet therapy with both aspirin and clopidogrel, which had a clear reduction in subsequent events. However, our attempts to intensify platelet inhibition by substituting either more potent agents or adding a third agent has often resulted in more frequent bleeding. Aspirin and prasugrel were used in the Triton-TIMI-38 trial. Aspirin and ticagrelor were used in the Plato trial, and vorapaxar was added to aspirin and clopidogrel in the TRACER study. But all of these were associated with more frequent bleeding. The thought then arose that maybe using an anticoagulant in addition to dual antiplatelet therapy would be beneficial. But when rivaroxaban was added to aspirin and clopidogrel in the Atlas ACS TIMI 51 trial, bleeding again was increased. So the longer-term risk following an acute coronary syndrome is probably due to the presence of multiple active plaques that may be found throughout the coronary tree following an acute coronary syndrome. These unstable or vulnerable plaques are remote from the culprit lesion and are responsible for further thrombotic events and myocardial infarction. And of interest, the frequency of these multiple active plaques increases with an increasing level of C-reactive protein, a marker of inflammation. Now, recently, inflammation has appeared to be a new concept, but it in fact is not new. And Rudolf Virchow, in his lectures in Berlin in cellular pathology in 1858, made the statement that I have therefore felt no hesitation in admitting an inflammation of the inner arterial coat to be the starting point of the so-called atheromatous degeneration. And what is this inflammatory response? Firstly, we know that there's an association between localized endothelial dysfunction and the underlying lipid core. The systemic effects on the endothelium are well recognized. Cardiovascular risk factors affect it, altered shear stress affects it, and circulating inflammatory factors affect the endothelium systemically. But focal endothelial dysfunction is also at fault, and macrophage foam cells that produce interleukin-2, tumor necrosis factor, and TGF-alpha contribute to creating focal endothelial dysfunction. And very recently, Choi and his partners produced a paper showing that the abundance of lipid within the plaque core is also responsible for focal endothelial dysfunction, probably due to the emanation of cytokines and promoting lipid ingress into the lipid core of the plaque. Now, the nature of future culprit lesions is well characterized. Of interest, these are often found proximal to the site of maximal stenosis, and they infrequently impair the coronary flow. In this diagram to the left, you can see that there is no obstruction to the luminal diameter of the vessel. There's a large lipid-rich core, depicted in yellow, and there's positive remodeling, with the plaque expanding the arterial wall rather than encroaching upon the vessel lumen. The fibrous cap is thin, between 50 and 65 microns, and there are abundant inflammatory cells in the region, associated with a paucity of smooth muscle cells and only minor punctate or absolutely no calcification in this region. And so, turning to the pathogenetic mechanisms that underlie plaque rupture, in the cartoon we see at the top the endothelium and beneath that collagen, and T cells that produce interferon gamma affect the smooth muscle cell production of collagen and decrease the amount that is available to strengthen the plaque cap. Furthermore, the T cells interacting through the CD40 ligand mechanism with macrophage foam cells produce matrix metalloproteinases, which increase the collagen degradation, so that we have both decreased production and increased degradation, which weakens the plaque cap and promotes plaque rupture. So, in conclusion of this brief presentation, it's clear that our current treatment does not directly address the underlying causal mechanisms of acute coronary syndrome, namely plaque rupture, which is the predominant one in 75 or 80% of cases, and plaque erosion, which is active in 20 or 25% of patients. Our currently available diagnostic methods do not readily identify the individuals with vulnerable plaque. And treatments need to be developed that target plaque cap stabilization and inhibit plaque erosion before intimal disruption can occur. All of this will require a very intimate knowledge of the biology of atheromatous plaque and the means to selectively alter its biology. Thank you. We have, with statins, achieved a major improvement in the outcome. The problem is that that improvement probably accounts for 30 to 40% of the residual problem, so that we're left with a considerable number of patients who will still experience events. Now, two theories surround this. The one is, are we lowering cholesterol enough? Or is this another mechanism working through inflammation that will be active and which would allow for this continued event rate? At the moment, we've got statin therapies that are fairly potent, but new agents such as PCSK9 inhibitors are able to lower cholesterol to dramatically lower levels, and trials are ongoing to investigate whether this might have an effect on the outcome.